We have a saying at the University of Maryland, Baltimore, that we're changing the future today, that we have a responsibility as the state's public health, law, and human services university to help shape the future in ways that benefit not only Marylanders, but society in general. We do that through groundbreaking research and education, treating patients, and through community outreach, just to name a few ways. Given the recent changes at the federal level where funding for critical research is being withheld, that is a challenge right now to make sure that we're not losing progress. So that's what makes this conversation with Dr. Wilbur Chen particularly timely and important.
Dr. Chen is a professor of medicine at the University of Maryland School of Medicine, and he's a renowned expert in infectious diseases and vaccinology. He will tell us shortly how he got to that position and why. He's the chief of the Adult Clinical Studies section within the Center for Vaccine Development and Global Health, more commonly called the CVD, as you'll hear him refer to it multiple times. He's also an alumnus, earning his master's degree in clinical research in 2008 from UMB. And Dr. Chen has and continues to serve on several key committees and task forces, including being a core member of the National Institute of Allergy and Infectious Diseases Data and Safety Monitoring Board. That board ensures the safety and integrity of clinical trials. He also served a 4-year term ending in 2024 on the CDC Advisory Committee on Immunization Practices. That committee is a very prestigious board that makes recommendations for the safe use of vaccines for Americans. Now, folks around here at UMB, you will likely remember Dr. Chen for keeping the community regularly updated during the pandemic when he also served on the governor's COVID-19 response team. So we'll not only dive into his research, but we'll also demystify some of the processes, including how indirect costs and grants help fund research.
It means a lot that everybody tunes into the UMB Pulse, and we want this to keep on happening. So please subscribe and like our videos on YouTube, and give us a 5-star rating and review on your favorite podcast platform. And with that, enjoy our conversation with Dr. Wilbur Chen.
You're listening to the heartbeat of the University of Maryland, Baltimore, the UMB Pulse.
Dr. Chen, thank you so much for joining us today. We know your time is limited and valuable. You're a very busy man, so thank you for carving out time to speak with us.
Oh, I'm pleased to be here.
Wonderful. Let's dive right in and talk a little bit about you as a person. How did you get started in infectious disease research? Is this something that as a budding scientist coming up through high school, the bug just hit you, or did this grow as you began and continued to study medicine?
Yeah, I think we can take this question with an answer that goes really far back. So I am the son of 2 immigrants who came to the US from Taiwan from the early 1960s. They came to the US to pursue PhD degrees. And I grew up as a child in the 70s and 80s, again, with scientists parents. And so when I went to high school, I did get the opportunity to do some research over the summers at the NIH. So I kind of continued to explore scientific research. When I went to college, I actually worked part-time in the clinical microbiology lab of Boston University Hospital and really enjoyed that experience. During that time, oftentimes the clinicians would come down and do plate rounds with me, and we would talk about some cases, and I would pull out plates and we would review them, and then they would tell me about the kind of the patient histories and those sorts of things. I thought that was really fantastic, kind of how the microbiology that I was doing, they were allowing me to see the kind of clinical context for why these were important. So when I finished college, I did not go directly into medical school. I actually spent 2 years working at the Food and Drug Administration. And this was the early to mid 1990s. And I happened to be working in the lab of bacterial polysaccharides in the Office of Vaccines Research and Review. That's to say that it was basically a vaccine lab. And this was the specific lab that was tasked with reviewing the newer vaccines that were being launched at that time, which was the Hib conjugate vaccine. And what was coming soon was pneumococcal conjugate vaccines. And the reason why I mentioned that is because people in my field understand that those conjugate vaccines were remarkable because of how they were able to make these vaccines highly effective for very young children. And then we started seeing that these, for pneumococcal vaccines, could be extended to older adults as well. So basically, a huge improvement in vaccines through a technology that we basically call protein conjugation of polysaccharides. And so again, that was a remarkable experience, even though it was just a short 2 years, such that I felt like, wow, vaccines research seems to be a really exciting field. So I went to medical school already with the notion during those 4 years that I was probably going to do infectious disease with my microbiology background, and then more specifically, wanted to focus on vaccines research. And so I never looked back. I plowed ahead. And the only kind of decision point during medical school was, did I want to pursue a pediatric background or internal medicine adult infectious disease background when I pursued my residencies and then my subspecialty training in infectious diseases. But either of those pathways would have still probably taken me to doing vaccines at the end. So right now, I'm an adult infectious disease physician that does vaccine research. But actually, a lot of my vaccine research is directed not just at adults, but also, because of these pathogens afflicting young children, pediatric vaccines as well. So it's kind of, a pretty straightforward path that I think, goes as far back as just my parents showing me the love of science and scientific discovery.
That's wonderful. And of course, we're excited because you are also an alum of the University of Maryland, Baltimore. And how did that fit into your trajectory?
Well, actually, it's a very conscious decision that after my residency in internal medicine, to come to the University of Maryland, Baltimore, the School of Medicine, because it has a very strong infectious disease training experience, and specifically because of the Center for Vaccine Development and Global Health, which again has been established since 1974 and is really an extremely strong institution. It's really, bar none, the foremost kind of institution. If you want to do vaccine research, it's the CVD.
That's terrific. Well, you certainly balance a lot of research. We kind of gave a nod to that in our introduction. So tell us, what does a week look like in the life of Dr. Wilbur Chen between research and your federal committees, work groups? It just sounds like your job never ends.
Yeah, well, it's always a balancing act between all the different commitments. I'm committed to my research programs that I have funded. Many of them are funded by the NIH, federal funds. But I also have some research projects that are funded by the Gates Foundation and by Wellcome Trust. So two large kind of charitable foundations that really are concentrating on global health and science. And apart from that, I also have a hat that I wear on this campus where I am the co-director of the K-12 program. So really, it's a commitment to junior faculty to help mentor them and train them so that they can make that transition from being a junior faculty member to being an independent scientist. So I'm really committed to that aspect as well. And then I have a little bit of clinical duties because I have a travel medicine practice that I run, which again, really synergizes with what my research is doing, which is trying to develop vaccines. And then once they are actually licensed, we can implement them and use them in the travel clinic, because these are people who are going to far-flung areas of the world where they might be at risk for getting some of these infections. So it's actually allowing me to put these vaccines into use locally, even though most of these vaccines are intended to be used kind of wide scale for populations outside of the US.
I want to start by setting the stage. about what these projects are and why they matter, especially on a global scale, how something across the world can impact us right here. And we've had these new directives by the federal government where they're withholding funds that have already been appropriated by Congress. New grants from NIH are not being awarded. And then there's something called indirect costs, and those are being scrutinized too. And the general public is finding out what those are, and they probably never heard about that term in their lives before this year. They are being challenged in courts, so we'll have to see if these court orders are being followed. For the average person, they may not understand exactly what's going on, why it matters. Some people might believe it's an issue of overspending and waste. Others might see it because they just don't know how the funds are being used. So with all of that said of what's happening right now, just start off by sharing with the listeners some of the major research that you're doing now that's federally funded and how that connects to everyday people.
Yeah, so I don't know if I'm going to answer this in the best way possible, the clarity that I want. But I'd like to just mention that this indirect cost that is being discussed is really acknowledging the huge infrastructure that an organization, a university, provides for the researcher. And so when an individual like myself writes a research grant, we are thinking about specific personnel, materials, and supplies that would be directly used for the research. But we're not accounting for the fact that I've got a climate-controlled office that's heated and cooled, that has electricity, that has Wi-Fi, that has, is behind a well-established firewall to keep all of my records secure. And all of that requires an infrastructure that the university has to put into that. And it's increasingly more difficult to have an IT infrastructure that is resilient against cyber attacks more and more. So you can imagine that there is a lot that goes on in the background that the university has to provide that is not being accounted for with the direct costs of my grants. There are, the parking facility, the lawns get mowed, the fact that, we have the hallways cleaned, the trash taken out, all of these things. Again, you're thinking about infrastructure that some people may just assume is there, but is our real costs to a university or any organization. Baltimore may not be the most expensive location, but it is an urban city. And again, so all of this means that there are a lot of other costs that are indirect. And so I think that has to be acknowledged, and 15% has not traditionally been sufficient to really be able to recover those true costs that are being spent, whether I get grants or not. So, I think that's kind of one thing that, when we talk about indirect costs, how did the government come up with 15% as appropriate? And if that's the case, then I think that there has to be a mechanism in the future for persons like myself to then directly cost out what is the cost of this infrastructure that I get to enjoy. I'll have to probably start paying rent for my office. I'm using this office. I don't pay rent right now, but if we're not going to be able to cover it with an indirect cost rate, then probably the university will have to levy a rental or something like that. And I'll have to put that on my grant. I'll also have to put other things on my grant as well that will be part of the infrastructure, but then it'll be a direct cost rather than an indirect cost. Is that appropriate? I again would have to have other people that are better in the know to be able to be in the conversation as to how we would change, the way that we are structuring grants and talking about direct costs versus indirect costs. I'll just segue as a physician. So, we oftentimes say, what is the cost of a person getting an illness, a disease? So, okay, the cost is they're hospitalized, so the hospitalization fee, the cost of the medications that they have to take, and whatever. There are indirect costs of getting ill as well. So if a child gets ill and they have to remain at home, the parent probably has to take time off of work. That's an indirect cost of that illness. And they may lose work hours. So if they are an hourly wage worker, they will lose however many hours. And if it's multiple days, it might be multiple days worth of work. That's an indirect cost for many economists, kind of even looking at the cost of illness. You're also looking at the indirect costs of other inconveniences during an illness or a disease. So I think, again, when we think about cost, there are other things, that are oftentimes not discussed that are a reality as part of the problem.
Some of the examples that I've read that included, like, as you mentioned about power, well, going a step further, you need to keep samples refrigerated at a certain temperature, right? And so that's part of it. Or if there are animals involved, you need to pay for their care and their food and their water too, and make sure everything's, going according to standards as well. We should note that in recent days, the federal judge granted a preliminary injunction to stop the across-the-board caps on these costs, but we still have to see if there will be compliance with that order and if those will be, released and the caps will go into place. Have you had any research impacted by either the guidelines or just the process that's going on right now?
I have not directly been impacted, but I think that most of the faculty here at my center are looking at what are the prospects of their continuation of funding. We don't know, first of all, if we have a 5-year grant, whether we're going to get the next year's grant money, whether it might be reduced. And then for new grants that we would like to submit, or maybe we're in the submission process, we don't know if they will be successful. There may be less funding initiatives for us to apply to for federal funding. I mentioned that I have Gates Foundation, Wellcome Trust, but there are other sources of funding as well. A lot of them are traditionally federal funding sources, so NIH, CDC, or even DoD. And a lot of those federal funding sources may start to dry up or really be limited, which means that you've got a pool of people who are competing against a smaller amount of funds available. And so that becomes much more competitive, which means also that for junior faculty members, younger scientists that aren't established as well, they may be ill-equipped to compete against the senior scientists that are really well established. So, part of the consequence is that you might have a chilling effect on the next generation of scientists until we can correct the situation, because I think a lot of scientists are really, junior scientists are really, progressing in their own fields.
Wilbur, I have a couple of questions for you about your specific research, and I'd like to start off just to give you the opportunity to share if there's any recent advances or breakthroughs that you're particularly excited about.
Yeah, several things that I'm working on. One thing is that I'm working with our sister site in Mali, a country in West Africa. It's in the meningitis belt of sub-Saharan Africa. And since at least 2015, we've been developing a pentavalent meningococcal conjugate vaccine, which is supposed to address all of the so-called serotypes of meningitis that cause invasive meningitis disease in sub-Saharan Africa. Well, it's gotten to the point in the past year that we've done a phase 3 clinical trial that we're completing right now, that this vaccine was licensed last year and WHO recommended for sub-Saharan Africa, and it was based partially on the phase 3 study that we just completed. Some of the recommendations were adjusted because of our data as well. We're presenting these data at an international meeting next month, but it's really just a representation of how we've been able to collaborate across the world, in specific for this one with our sister site, CVD Mali, who's been a great partner. And this is the way that we try to address kind of, the important global health problems where they actually occur is we partner with collaborating sites that are afflicted. And it also provides us the opportunity to be able to mentor, teach, educate the next generation of scientists locally for those nations. And so a lot of Malian scientists have come here to UMB to get their advanced degrees, their PhDs, and then we send them back. And they become prominent scientists in their own right in Mali. So that's kind of kind of exciting, is that we continue to be able to partner with sister sites like that on important issues. This pentavalent vaccine study will be published next week. There's an embargo, but it'll be published in the Lancet. So we're really happy about that. And then we'll have a follow-up publication as well for the 2-year persistence of this vaccine. So it's really kind of moved along, and this is kind of, again, 10 years coming to fruition. On the other end of the spectrum, we've got another vaccine that we're developing, a pentavalent meningococcal conjugate vaccine, which is supposed to address all of the so-called serotypes of meningitis that cause invasive meningitis disease in sub-Saharan Africa. Well, it's gotten to the point in the past year that we've done a phase 3 clinical trial that we're completing right now, that this vaccine was licensed last year and WHO recommended for sub-Saharan Africa, and it was based partially on the phase 3 study that we just completed. Some of the recommendations were adjusted because of our data as well. We're presenting these data at an international meeting next month, but it's really just a representation of how we've been able to collaborate across the world, in specific for this one with our sister site, CVD Mali, who's been a great partner. And this is the way that we try to address kind of, the important global health problems where they actually occur, is we partner with collaborating sites that are afflicted. And it also provides us the opportunity to be able to mentor, teach, educate the next generation of scientists locally for those nations. And so a lot of Malian scientists have come here to UMB to get their advanced degrees, their PhDs, and then we send them back. And they become prominent scientists in their own right in Mali. So that's kind of kind of exciting, is that we continue to be able to partner with sister sites like that on important issues. This pentavalent vaccine study will be published next week. There's an embargo, but it'll be published in the Lancet. So we're really happy about that. And then we'll have a follow-up publication as well for the 2-year persistence of this vaccine. So it's really kind of moved along, and this is kind of, again, 10 years coming to fruition. On the other end of the spectrum, we've got another vaccine that we're developing here at CBD, which is intended to prevent typhoid and non-typhoidal salmonella, NTS, which is also another kind of disease and pathogen that afflicts sub-Saharan Africa, especially very young children. It causes invasive bloodstream disease, and it's similar to Hib and pneumococcus. So this is a vaccine that is really specific for sub-Saharan Africa. We finished 2 phase 1 studies, and we're now in the midst of a phase 2 study in Africa, in actually 3 sites in Africa, our sister site in Mali, but also in Kenya and in Mozambique. And again, we're working with local partners that are really terrific scientists, but we have a vision for taking this in the next few years to a phase 3 pivotal efficacy study. And if that's successful, then hopefully we'll be on a licensure pathway in which we might have a vaccine, again, developed by the CVD, that might be licensed within maybe 5 to 10 years. So that's really exciting. And it, again, is addressing a real problem in sub-Saharan Africa. So that's another vaccine that we're really proud of. I've also got a number of research programs on enteric diseases. So these are diarrheal diseases. So cholera, Shigella, enterotoxigenic E. coli, Campylobacter. And so I've got, a few Shigella studies that I'm wrapping up and writing manuscripts. and a couple of enterotoxigenic E. coli manuscripts as well. These are all kind of smaller studies that we did here in the US, but should any of these be kind of successful vaccines, we would want to progress them and take them to sub-Saharan Africa or Southeast Asia, where we see a lot of diarrheal disease. So again, I'm trying to provide you the this ideation that CVD, we work here in the US and in Baltimore, but our vision is that, we have no walls. We really work globally. We're always trying to do what we can here in Baltimore, but immediately go out to the places where people are afflicted the most. And we want to kind of make sure that we're making scientific discoveries that actually are changing people's lives.
Well, and if we're listening to the news right now, we're hearing how some of the talk is that this type of research and aid, some people may feel that this shouldn't be happening. We should be focusing strictly here at home. What's your response to that? Why should we be continuing to do research in other parts of the world?
Yeah, I think that, when we talk about research such as the stuff that I'm doing, which is preventing diseases through vaccines, we're talking about protecting people's lives. We're also talking about a way to generate stability in a population. And stability can be political stability, but it can also be kind of the ability for a person to enjoy economic mobility, to move up or down. And if you have countries and populations where they have less of an ability to stay stable, that presents a security problem for the rest of the world, because that population will perhaps not be stable and migrate, not be stable and have political unrest and civil war. And again, those diseases may continue to spread worldwide. So I think that there are a number of reasons where we as US citizens would want to be interested in protecting the rest of the world, because it ends up that if the rest of the world is stable, then we can also enjoy stability at home too.
Thank you for sharing that. I want to shift for just a little bit and talk about something else that is happening here at home, which is also on the news quite a bit. We keep hearing about measles cases in the United States with that notable outbreak just recently in Texas. There was another exposure reported in Philadelphia. I think that was on March 4th, so just a few days ago. What's driving this resurgence and how concerned should we be?
Yeah, so what I'm hearing and seeing is that there are populations in these places where they're having outbreaks that have had a pretty low vaccine uptake for measles-containing vaccines. And we know these measles vaccines are highly effective, but it needs 2 doses to get to 95% protection, where again, that still means that even despite vaccination, there might be 1 in 20 people that might be susceptible to getting in measles if you have the entire population being exposed to measles. So in other words, it means that you need to have pretty high uptake in your population to continue to reduce or have no spread of measles in that population. In areas of West Texas and other areas, we've seen that measles vaccination rates have dropped below 80%. So what's going to happen is that you're going to have these measles outbreak in these populations. Now, in populations that are highly vaccinated, you still may have a risk of people having measles, but it might be only among the immune compromised, who again don't respond as well to vaccination, or again, that 1 in 20 case where again, even despite being a healthy person, getting those 2 doses, you just didn't respond. But that's, again, a very small percent, 5% or less. So again, if a person has received 2 doses of measles vaccine, they have nothing to worry about, especially in our population that's highly vaccinated. But for those other populations that have very low uptake, I know that public health authorities and CDC officials have also sent representatives to those populations to try to see if they can increase vaccination rates. So I know that they're holding vaccine clinics, also trying to speak to those populations and talk about, what are the risks of vaccination and then what are the true benefits? Because unfortunately, there's a lot of vaccine hesitancy that is driving the low uptake of vaccination. And that's become worse and worse over the past few years. And again, we need to counter that with, true data. And again, there's unfortunately a lot of misinformation and outright lies that are being promoted. And again, that's what we have to work against.
I think with measles, it's one of those things where maybe people don't understand the difficulty of having measles, how dangerous it can be, and how contagious it is because it was eradicated and we didn't have to worry about it for so long. And so, like in the case of the person in Philadelphia, according to the health department, that person first traveled on a plane. I don't know if it was from another country or another state, but they arrived through JFK. So, just paint us a picture, like if there's one person with measles on an airplane, how contagious is that?
Yeah, measles is probably one of the most contagious pathogens that we know of. The way that we think about it is that it has an R naught, or basically a reproductive value of somewhere between 14 to 19, which means that it can be highly infectious. The way to illustrate that number is basically if a person were to come into an enclosed office space like my room right here, and they were infectious with measles, and they were to breathe into this space and then leave, this airspace would be infectious for the next 2 or 3 hours. So if another person walked into this room, and that person was already gone, but walked into this room, they potentially could get infected with measles if they were not vaccinated. So that shows you how highly contagious it is. This person having kind of flown in a plane, an enclosed kind of cylinder, potentially could have exposed a number of people on that plane because of recirculating air to measles. So hopefully the people on the plane were highly vaccinated, but again, for people who didn't receive their full 2 doses, they might be at risk for getting measles. Same with this person walking through the airport terminal. The people around this person may have been inadvertently exposed by infectious breath. And so again, so that's kind of the things that public health officials are tackling when they're trying to respond to these measles outbreaks.
And when we hear about air circulation, contagious and everything, for people maybe not familiar with measles, they're thinking, oh, this sounds like how we thought, with COVID spreading. So if someone is on a plane, would a mask afford extra protection through that, since we're dealing with that similar environment?
Yeah. I think a mask, and a well-fitting mask that's like an N95 mask with a better kind of filter mesh, would be better than nothing. The best situation were if the measles infected person were to wear the mask. It's less effective for the person who's not infected, who's trying to protect themselves from a person who's infectious, because we unfortunately have other mucous membranes that are exposed, so our eyes, ears, and whatever else. And then we can also, if we were to unmask because we were going to drink or eat or something like that, breaks that barrier. So it's much more important, if we know a person is infected, for them to wear the mask. Again, filtering right where their breath is coming out. But it is a measure that is better than nothing. I do wear a mask when I'm on a plane if I think that I might be exposed to a pathogen. Again, if COVID is raging and I'm on an international flight. But I recognize that it's really not the optimal situation, but there is no kind of correction of an optimal situation because I don't know who is infectious at that time.
I personally have never known anyone to have had measles, and I think many of our listeners might be in the same situation. As Charles said, we haven't had cases for a long time. So for the person who's listening who says, it's not that big of a deal, it's kind of like chicken pox or the cold, give us a little bit of information about why it is important.
Yeah. Well, so, it is a febrile illness that is encountered typically by kids, but again, we can have it now circulate in adults that are unvaccinated. So you get a fever and you get this very kind of, remarkable rash that's throughout the body. You feel terrible. And then oftentimes you recover. Now that's the oftentimes, but there are some people that will get hospitalized and have a very severe pneumonia as a result of getting measles. And then there's 1 in 1,000 people that will die from measles. So again, 1 in 1,000 doesn't sound like a lot, but if you've got 1,000 people that are encountering measles and you have 1 death, we've already had 1 death, maybe 2 deaths. I wasn't really sure about the reporting, and this was, I think, just last week, but there was certainly 1 death that was reported due to measles. So that's kind of, again, about right, 1 in 1,000 cases. So I think that, again, to say that it's just like chickenpox, which again in children is milder, less severe, but in adults can be severe and cause pneumonia, hospitalization, and death. I think that we need to understand that these traditionally were, yes, childhood diseases that we encountered daily, but those were at the time when we didn't have vaccines available. And then a lot of people did die of vaccine preventable diseases during those times. And we're now in a different era where we've really eliminated some of these. And most physicians nowadays, during their training, have never seen measles before. It used to be that people would see measles every day. And so, again, it's the same with polio. People don't really understand how devastating polio was, how fearful people were in the 50s and 60s whenever it came to the summertime, because that's when poliovirus infections surged, that people sometimes didn't really know if they were going to make it through the summer without being infected and possibly being debilitated for life and have a crippling, paralysis or something like that. So again, that was a fear that people grew up with routinely that has disappeared from people's consciousnesses now. And so, I still see it in developing country settings where we're still seeing measles resurge and we're still seeing infants dying from it routinely, unfortunately. And that's why, for me, it's important for me to continue to promote these vaccines. But it's too bad that we've had near elimination here in the Americas, and now we're seeing a resurgence. So we're really taking a back step.
Can you vaccinate as it's getting closer to their town? Does it work? I know you said you have to get the 2 doses in.
Yeah, absolutely. Absolutely. They should immediately talk to their pediatrician and have their child vaccinated and caught up with all of the rest of their childhood vaccinations if they've also declined other vaccinations. I imagine that a child that hasn't received their measles vaccine probably had declined other vaccinations as well. So I think it would be a great opportunity for that child to get caught up.
Well, moving to another outbreak, you've had experience working with the avian flu. What is, other than the price of eggs, what is happening now with the latest avian flu outbreak? How's it different from the previous ones?
I started kind of avian influenza research back in 2005. And this was when kind of H5N1 first broke out. And this was in mostly Southeast Asia, had not reached the US. But we knew that it was something that was endemic in migratory birds. And that's where, again, these avian influenza viruses are in birds, avian. And migratory birds, have a very large migration flight pathway from the summer to the winter. They may, summer in the southern hemisphere and then winter in the northern hemisphere and vice versa. And that's really taking them from the Arctic all the way to the, to the equator and back within a year's time. And their flight, might take them from, again, northern parts of Russia all the way down to the tropical areas of Southeast Asia. The migratory path means that, again, they will fly to the backyards while they're flying to rest overnight, to the backyards of some of these farms or in a suburban backyard where, again, some people might have pet chickens or ducks or other domesticated animals. And so they'll share the pond and the lake and the water and whatever else. That's just migratory birds. That's just, kind of how they are. And because they're flying across, large areas of geographic areas, that's what they do. some of the migratory pathways, from the Arctic overlap with the migratory birds that fly from the Arctic and then along the western seaboard of the US. And so again, the Arctic, and then some of them fly up and down like Arctic to Southeast Asia, but some of them also fly from the Arctic down to the western seaboard of the US. There are other ones that fly the central US and others that fly the eastern US. So you can imagine that again, these migratory pathways overlap. And so these birds trade these infections, these viruses. Eventually, by the 2010s, avian H5 influenza virus was introduced to the US. And again, it was kind of predictable because of migratory birds, the way that they fly and their landing and training. And eventually what we're seeing right now is that they're now entrenched in many of our domesticated animals because they first were flying along the western and central, pathways of the US and landing in farms. Dairy cattle got infected because of their, close proximity. Chickens get infected, are domesticated animals. Humans inadvertently get infected, probably not from the migratory birds, but again, because they are farm workers or working around dairy cattle or whatever else, inadvertently get infected. We're eventually going to get to the point where these viruses are so commonly transmitted among our domesticated animals and back and forth perhaps to humans inadvertently, that eventually we might have enough mutations in the virus that it gains the ability to be very efficient, transforms to a human virus. Remember, it started out as an avian virus, and it eventually can mutate, have enough mutations that basically it is efficient in humans, and we call it a human virus. That's kind of what happened in 2009, which was not an avian virus, but it was originally a swine virus that also had some avian components as well, and then became a human virus. So 2009 H1N1, that was a pandemic as well, and that was because of, again, we know how these influenza viruses eventually become humanized so that they become efficient and can afflict humans. So that's kind of what we're looking at with avian influenza, is that we've been studying it for now 2 decades and more, and it was predictable. So I've been kind of on the end of trying to develop vaccines against avian influenza viruses, and we have a number of candidates that we've evaluated with the federal government's help. And these are actually vaccines that are now stockpiled by the US government. BARDA is the kind of group, the federal agency that kind of stockpiles them. But these are stockpiled and they represent H5N1 viruses, H7N9 viruses. So we are pre-positioning ourselves to be able to respond to whichever virus eventually does break out in humans. Right now, I know that they are trying to manufacture a vaccine that matches very closely to the ones that are, being transmitted among dairy cattle, so that we have a very closely matched vaccine. And those clinical studies are probably in progress right now. I haven't been involved with them. BARDA is the agency that's now taking it up, less so by NIH. So, but this is the kind of activity that's going on, really to be prepared for what we perceive as an inevitable pandemic that will be coming.
You mentioned the vaccines, and so I'm thinking, like, how do you get this under control? What's the, plan for the vaccinations? Are we trying to do it on the front end of it and trying to vaccinate migratory birds, which should be fun as they try to fly away when you catch them? Or is this something where, if I have a dog or a cat, is this a vaccine that I'm going to have my vet give my pets every year, or however often that it would be needed?
Yeah, I can only give you my thoughts because there are other people in higher levels of government and, advisory that are thinking about this specifically. Influenza viruses are smart. They've been with humans or on the globe, in the world for centuries, not just, in the past few decades. So, and these viruses are smart in the sense that they rapidly mutate. And that's why we have to kind of adjust our seasonal influenza vaccine to an annual vaccine every year, where we switch out the components. So I don't think that a strategy to vaccinate migratory birds is ever going to work, because you can vaccinate them, but the virus is going to mutate and what we call shift and drift. And those will then be the newer viruses, and we won't be able to catch up with it. We can't even catch up with the human ones from year to year because we have to do an annual one. Now, it's interesting that you mentioned dogs and cats and other domesticated animals. So I think that, again, trying to prevent avian influenza into important animals in our economy and our agriculture could be a very important way to address this issue. And I think, we could have programs where we're vaccinating our dairy cattle. We could have programs where we're vaccinating our egg-laying hens and other poultry kind of production facilities, part of our food systems. I've heard that the problem with vaccination, again, is that it may not completely eradicate the infection. It also causes it to be more difficult to identify whether a chicken is infected or not, because sometimes they'll be testing the blood of the chicken. And is it due to vaccination or the infection? That's kind of the question. So I've heard that argument as well. Although I think that we've got better technologies now than 10 years ago and 20 years ago, that we might be able to have better systems to vaccinate. How many vaccines do we have to kind of manufacture to be able to do this? So if you wanted to vaccinate the entire population of the US, it's 210 million. How many food animals would you have to vaccinate? I've heard some crazy statistics, but think about how many chickens that you might eat in a year collectively, right? Chicken wings, chicken breast, chicken thighs. That's a lot of chickens per person times 210 million, right? Dairy cattle, we drink a lot of milk. I drink a lot of milk. And so I'm wondering how many dairy cattle that is. That's a lot of vaccines to manufacture. Is there a market for them so that manufacturers will be enthusiastic to make them? There has to be a market force, maybe, to generate the enthusiasm to make these vaccines highly available. And we're only talking about the US now, but now we're talking, let's say, okay, now we want to also protect our Canadian neighbors. We want to protect the rest of the world because we export a lot of our agriculture or foods. So again, we're talking about now, larger systems in which we would have to vaccinate. So that's kind of the complexity in my mind. I think it's an interesting question, which I think is very valid, how we can address this avian influenza problem overall with vaccines. I think it has to be a combination of vaccines, but other interventions is my idea.
Mm-hmm.
Of course, I love vaccines, and I think vaccines are always part of the answer, but I don't know, again, how much can be done with just vaccines alone.
Yeah. And I know everyone's seeing the effect of it from the food part of it, seeing the price of chicken and eggs, and that's a real economic cost. But I don't know how often people realize how important chickens are for other things. Dana, you have family in Florida. I lived in Florida for a little bit, but something called sentinel chickens that placed throughout a county because they are your signal to see if West Nile virus or encephalitis is spreading or other mosquito-borne diseases. So we need chickens alive to tell us if there's something else coming down the pike other than bird flu.
Yeah, my family's just opting to raise their own chickens. So we have a lot of little mini chicken farms in our Florida family yards. So I guess the big concern is that not only does it reduce the chicken population, which in turn affects the egg population, but they're not transferable directly to humans, but they're evolving some way to become human.
That's right. At least right now, avian influenza viruses are not efficiently transmitting from human to human. That's good news.
Right.
But as I said, we know these viruses continue to mutate. And it seems to me an eventuality that it'll learn to be able to be efficient at infecting humans, as well as, it learned to be efficient to infect cows at some point. So, and now we're seeing them in cats as well in these dairy farms. So, I think, again, we need to be pre-positioned for the eventuality that it might come into humans. Now, when COVID broke out, I was a betting person that I thought the next pandemic was going to be avian influenza. But of course, now it was a coronavirus. So again, who knows what the next pandemic will consist of? But it could be a different coronavirus. It could be an avian influenza or some other pandemic influenza. It also could be some of these other emerging viruses that we're seeing throughout the world. Ebola, some people hear about those. Zika, is another kind of virus that's mosquito-borne. Chikungunya, dengue, these are all mosquito-borne viruses, very important for the tropical areas of the world, but because of global warming, the areas of the world that are affected by these mosquito-borne infections is becoming broader and broader, such that they're entering into subtropical areas and maybe eventually entering into temperate areas of the world. So southern tip of Florida and parts of Southeast Texas have had introductions of malaria and dengue, again, because it's warm enough that we can see these mosquitoes able to persist and cause these infections and infect humans. So with global warming, the trend is that we'll probably continue to see that kind of encroachment of these emerging pathogens that we see throughout the world enter into the U.S.
Wilbur, can you share a little bit how, once people know that these infectious diseases are out there, they are on the horizon, what do you do to kind of start to think about developing those vaccines and testing them? What's the process for that?
Yeah, that's a great question. That's what we do all the time at the CVD internally, is we ask ourselves, what are the emerging pathogens that we're seeing throughout the world that are continuing to expand and threaten human populations? And are there vaccines that potentially could be available? And should we start maybe developing one from the grassroots? Or maybe can we partner with another academic group or another small or large biotech to see if we can advance their vaccine candidates? And it might be therapeutic candidates as well, if it's an antiviral or something else. So we're always kind of looking at that. It's basically trying to assess through surveillance that is being conducted throughout the world. And some of it is our own surveillance that we put together that we're implementing in other areas of the world, where we try to identify, what's the biggest burden of disease that's causing diarrhea, that's causing malaria, that's causing whatever. And what can we learn about these pathogens? And now, do we need to pivot our research priorities to be able to address them? So again, just kind of mentioning within the CVD, we are recognizing the importance of climate change, global warming, and we're trying to pivot to try to see if we can kind of grow some of the programs that we have internally, try to partner with people and see if we can get ahead of this, because we know that it is happening. What is it going to do? And so I already mentioned that it's already causing the expansion of mosquito populations to extend further geographically. Also, global warming is causing more kind of rainfall and flooding, more severe kind of swings between drought and flood and hurricanes and cyclones and those sorts of things. So what that does is that increases the risk of diarrheal diseases, which is with access to, sanitation, hygiene, and clean water. And the clean water, again, is the key, because if you have flooding conditions, then your well can become contaminated. Your clean water systems can be contaminated. Your sewage, again, if it's not treated well, under flooding conditions, the sewage can basically be spread easily with the flood water throughout. So you can have an entire population exposed to raw sewage because of flooding. And again, that causes an outbreak of diarrheal disease. So the bottom line is that we think that global warming is actually a critical question that we need to grapple with in the next few years and decades, because it'll become increasingly important on a lot of different fronts.
Absolutely. Some people think in terms on a very personal level and not on a global level. But when you look at these things, think about like if you want to go on vacation in a nice tropical climate, think of all the symptoms that you just listed that could ruin your vacation: diarrhea, other sicknesses, mosquito-borne illnesses. So maybe if you want to not get sick on vacation in these nice tropical climates, support vaccines, support the research that we do, and let your representatives know that you want to enjoy your vacation and not come home with dengue fever.
That's right. Global problems can be local problems. I think that, again, the idea is that, we don't live in isolation because of our ability to cross borders. 50 years ago and 100 years ago, borders were more important. And the fact that the US was, separated from Europe and other countries because of huge oceans, I think that's not, going to be helping us as much these days because of, the ability to jump on a jet and be from one place to another within hours, that you could have importation of these infections. And then the globalization of even our food. So, kind of going back to, we are able to enjoy raspberries and strawberries in the winter, right? And that's because we're importing a lot of our fruits and vegetables. So that, it used to be that our parents probably grew up with, again, seasonal vegetables, where in the wintertime we were just eating root vegetables, and that's all we had. And, whatever was in season was what we got. But now we can get anything that our hearts want when we go to the supermarket at any time of the year. And it's because of the globalization of our foods. So that means, again, our foods could get contaminated, and we could have importation of infectious diseases such as salmonella. You hear about these tainted salmonella products all the time. It's, in fact, CDC says it's one of the top foodborne illnesses in the US, salmonella. But there are a lot of other things. So again, globalization, thinking globally, if you want to protect yourself locally, is kind of the way that I want people to think, because really, even though we think that there's a border, those borders are very porous. And again, a lot of things are coming back and forth. And I'm not trying to get political about kind of migration and this and that. I'm talking just about the fact that we do jump on a jet and can go to another country in hours, and that we get our food from other countries all times of the year. It's coming from somewhere else. And so that means that we, again, are exposed. Even though we think that it's a problem of somewhere else, it's actually a problem that's brought to us very frequently.
Right. I mean, just think about the invasive pests that we've had to contend with. Have we had to, have PSAs about killing spotted lanternflies,
Right.
10 years ago, or even 10 years ago, stink bugs and how annoying those are.
Yeah,
The kudzu vine that used to only be down in the south, that's now migrating northward.
that's right. Strangling all of our vegetation. It's
Right.
terrible.
Yeah.
Well, my husband and I were just talking the other day about the types of food, exactly what you just said, Wilbur, that we were served by our grandparents versus what we have now, and that you can get anything year round. But then what's at jeopardy by importing that food? Because it's not coming to us fresh. It's being picked in a raw state, and chemicals and, things have been applied to it in that transit to keep it safer, but also, and when I say safer, I mean to keep pests at a minimum and that sort of thing, but also to ripen it. So, like, what is the quality of that food? And we live in a bizarre world right now.
Yeah.
So,
Well, I think going back to that notion is that, we've got the USDA and the FDA that are federal agencies that are tasked with trying to keep our foods safe. And that means, again, if we cripple their ability for that simple function, that means that we could be, again, more susceptible to some of these infections and pests and whatever else. because we don't have the system in place that is needed to protect us. So it's kind of, either we stop buying imported products completely and go with just local, which some people do. But again, just recognizing that, again, a lot of the products that we are able to enjoy are internationally sourced. And there's a huge system that's in place to try to protect us as well, that perhaps is under-recognized.
Again, looking at what we want versus what we need,
Yeah.
It's a lot to think about, a lot to package up. Thank you for sharing so many different insightful things with us today, helping us to learn a little bit about a lot of these pathogens that are out there and giving us an education.
This has been an incredible conversation. Like Dana said, just learning more about the vaccination process, the research, what goes into it. This is the economy that builds Baltimore right now. And we're glad that you're part of it and keep doing the work that you're doing.
All right. Well, thank you so much.
The UMB Pulse with Charles Schelle and Dana Rampolla is a UMB Office of Communications and Public Affairs production. Edited by Charles Schelle, marketing by Dana Rampolla.